Our second presenter will be Emma Tarpey. Emma is a chartered physiotherapist with a PGD in the management of manual handling in healthcare and over 15 years experience specialising in complex manual handling. Emma works as a senior manual handling advisor in the NHS, as well as working independently as a clinical specialist in complex handling, supporting organisations within health and social care, including a specialist bariatric rehabilitation centre.
I'm Emma Tarpey. I'm a physio by background. I work for the NHS as a senior manual handling advisor, and I do quite a lot of work privately around supporting plus-size people. So my work's taken me interesting places, I think, anyway. I've worked with fire and rescue around complex extrications from properties when people need bringing into acute care. I do continue to work with a bariatric rehabilitation facility, and at the other end of it, I've done quite a bit of work recently with funeral service around dignity and death for the larger person. So I have a reasonable understanding of that whole journey. So thinking about rehabilitation of the plus-size person and the challenges of it. So I named this presentation The Good, the Bad and the Fabulous, and I have a few patients I'm going to talk about which will fulfil those categories. So if we start with the need for rehabilitation, I mean, ultimately, the need for rehabilitation in the plus-size person is the same as any other person. They are just bigger. But things that we see quite characteristic, or I see quite characteristic to this population of patients, it's quite common, I find, for acute admissions to be following functional decline at home. So you'll have people who maybe aren't coping quite as well as they have done previously. Maybe there's carer breakdown. Maybe they've had equipment failures, and the result of that has meant that their function has taken a bit of a hit. So they're on a downward spiral from that functional point of view. And sometimes it's about the environment around them. If they've outgrown their environment, they can no longer get through their door and they're not going out. So function declines even further. The second thing that I think really brings about that need is often the journeys into acute care are not straightforward. So we hear about people who have had long life falls and waited for a very long time for emergency services to get them up and off the floor. If there are difficulties getting them out of properties, they're waiting for fire and rescue, and at the extreme end of it to come and make structural adaptations, cut windows out and such like to get people in. And that delay on the way in can lead to what function that was there to start with being much worse by the time they hit the acute door. The last point I've got up there is the hospital-acquired deconditioning. So that is the case for all patients. It's quite topical at the moment about the effects of hospital-acquired deconditioning. And sometimes that is because people come in and they are genuinely sick and they're not able to maintain their normal level of function. But I would say that's the minority. Often it is hospital-caused acquired deconditioning because people come in and we don't have the right equipment, the space, the skill set, staff, all that sort of business. And as a result, there is a delay in them being able to resume their normal functional level or start to improve it. So all of these things kind of come together to mean it's quite common that we have plus-size patients that have come in for acute reasons, and then there is this need to do that really early start mobilisation with them. So the challenges that we face. Now, rehab is rehab. It's the same for everybody. You need range of movement, you need muscle strength, and you turn that into functional ability. That is exactly the same, whatever size the person is. But the things that can make it harder with this group of patients, the equipment. Now, there's a few things about that. Access to equipment, that's a really big thing. So that person's come in, do we have immediate access to what they need? And depends where you are. It's a bit of a postcode lottery. That might be a yes, it might be a no. But often that causes delays. So people are waiting for the right equipment to be able to start, and that hospital-acquired deconditioning is kicking in already. The second part to this is having the right kind of equipment. Now, we are in a position where there are amazing beds and mattresses for plus-size people, and that's really good. But our equipment, I think, is a bit behind the times, in that if you're bedbound and you're of a larger size, you're going to be okay. But if you want to get up and moving and you're of a larger size, it's more of a problem. And our equipment manufacturers are behind the times in that now we are getting people up and moving and we need equipment to support that. So I always say it's width, not weight. That's not quite true. But generally, if you look at standing and raising aids for larger people, they are very narrow in their footprint. And if you can't get your feet within them, it's going to make it really difficult for you to use them. Yeah? Weight is a problem, though. And I know certainly from working with the bariatric rehab facility, upward of 200 kilos starts to get tricky. Hitting 300 kilos, it's really hard. There is no standing and raising aids out there that functionally work to support people. Now, whilst that remains the case, there are really cool things we can do. We manipulate lots of different pieces of equipment to essentially do the job of a SARA steady or a standing aid. But whilst that's the case, it's always going to be difficult. Your standard size person comes in, maybe they've had a bit of a long life fall, they've had a difficult journey in, they're not quite at their same functional level. Nursing staff will feel really confident to use a SARA steady to get them up, sit them in the chair. That's not the case for the larger person. So that hospital-acquired cause deconditioning is already kicking in. Staff, space I've missed, that's really important. Kaz was talking about where we put people. So having space, point one, for all of the equipment that you need. If you've got a larger bed, a larger chair, people to go around it, you needing a big bed space. So we're into, do we need 2 bed spaces? Hospitals bursting, that's not always a possibility. But also it's whether it is the right kind of space. So certainly if you're starting to put gantry hoist in and such like ceiling height, sink placement, all those sorts of things come into it. And I know within my trust we have a list of spaces that we would like to put our larger patients into when they come in, and we work really hard to do that. But sometimes practicalities, we're bursting at the doors, you've got the space you've got, and we have to wait for that to happen. And until that happens, I can't get the right equipment in. Back we are again, hospital-acquired cause deconditioning is kicking in. Staffing is a big thing. Enough staff. Who's got enough staff? No one. And we do need the staff for this. But equally, I think something we don't often think about with the staff is firstly the competence, but also the confidence. So if we are using lots of different pieces of equipment articulated together to do the job that one could do if we had it, do they know how to use it? Are they safe to use it? But are they confident to use it? So if you're someone that works with this patient group all of the time and uses all of this equipment all the time, you're going to be really cool with it. But often on a standard ward, this is a once-a-year occurrence. So when it happens, actually the staff aren't confident to do it. So now they're waiting for someone with extra skill set to come in and help. Back we are again. Hospital-acquired deconditioning is kicking in already. Time, I don't think I need to explain that. We don't have enough time. It is challenging. It does take time, and we have to put the time and the staff into it. If we don't have it, often these patients get left to the bottom of the pile because they're harder, and if we've got the time to see more people, that's where the efforts end up going in. Staff skill set I've touched on, but I think patient engagement is really important here. So when I go to see people, patients, the staff will often say to me, they're really difficult. They're really difficult to work with. They're really challenging. They don't want to do it. Okay, some people just aren't that friendly. That might be one thing. But I always say to them, let's roll back in this person's journey. So they were at home. Maybe things weren't going great at home. They had a complicated journey in. They've been brought out of their comfort zone. They've been met by not the right equipment, not the right space, and staff that don't feel confident in what they're doing with them. Are we going to see the best of this person? Probably not. Do we blame them for that? Reality is, yeah, we shouldn't know, because actually it's often of our own making. And if you go and meet someone, and I always find they say to me, oh, you actually know what you're doing. Amazing. But put yourself in those shoes. If you don't feel like anyone around you has a skill set or expertise to care for you, you're not going to be wanting to engage and do the best that you possibly can. My last point is about appropriate facilities, and this is that onward management. So step-down facilities, rehab facilities, really strict admission criteria. Assist of 2 or more, probably not going in. Specialist equipment, probably not going in. So what I find, certainly from the acute side, is in our trust, I'd like to think we do a really good job of that early mobilisation and getting people up and going, but we don't have anywhere to send them. We end up rehabbing people in the acute setting because we're just up against barriers, trying to get people into what is the right placement for them to continue on that journey. So, first of my 2 patients to talk about. This is the one that I'm going to say is the bad. Not because the patient was bad, she was lovely, but it wasn't great. This happened quite a while ago, and it was one of the first patients I worked with who really made me think, there's got to be a better way. We've got to do a better job than this. So this lady came into our acute hospital. She'd had a fall, long lie, fire and rescue had to come and extract her. She came in through ED. In the first instance, I think we did a really good job. We assessed her, we turned around, and we got her back out in 48 hours because actually we know that's the right thing to do. The thing we missed is that what we hadn't picked up on was the fire brigade extracting her. So transport came, they picked her up, they took her home, they got to her garden, and they went, she won't fit through the door. What shall we do now? A bit of head scratching went on, and she was returned back to hospital, and she was readmitted through ED. So we readmitted her, medically optimised. There's nothing wrong with her. We just couldn't get her through the front door, and they couldn't leave her in the garden, obviously. So she came back. So she got admitted onto one of our acute wards. We called a professionals meeting and scratched our heads about what are we going to do about this situation. And what transpired was that actually this lady had had quite a few falls previously, and this was becoming a recurrent thing, this whole the fire brigade coming out and wrapping her up in a carry sheet and pulling her through the door. But she lived right on the boundary between two trusts, so she hadn't been to our trust before, she'd been going next door to them, so we didn't know about this. Fire brigade had, from the other falls, been posting her back in. Now, I always say to people, they don't do that, it's a one-way journey out, but for whatever reason, better known to them, on this occasion, they had been posting her back in. So nothing had been done about this access issue. So we called a professionals meeting. There was us from the acute side, social worker came in, transport came in. And we said, what we're going to do. And the social worker really said, well, I don't know why I'm here, because this is your problem. She's on your ward. Now, the downside to this, which normally is a really good thing, but in this occasion was a really bad thing, was this lady owned her own property. And because of that, the social worker said, just really nothing to do with me at all. So we tried to make the argument, and I remember sitting there across the way from her and saying, look, if this lady had come in, become a wheelchair user, and now was waiting on house adaptations because her wheelchair wouldn't fit through the door, you would offer her a step-down bed. And the social worker looked me straight in the eyes and said, yes, but that's not the case. She is fat. So we all took a breath, did not say what we wanted to, and the social worker went on our way. What then happened? We went out. So from the acute side, we went out to do a home visit to look at the scale of the problem. The patient's family member met us. So what we found when we got there, very narrow doorway, 2 steps up to a very narrow doorway. The front door had a radiator behind it, so it narrowed the opening even further because we couldn't open it the full way. Patient had previously been single room living. Carers had been in. She was a return transfer going from bed to chair. They pulled up the carpets because they'd been struggling with the return transfer. It was a picture of functional decline going on. We know that the falls were frequent. Carers weren't that happy. We looked a bit further around the house and we found in the kitchen that there was some fire damage above the cooker. Now, the patient didn't get there. That was the carers. What's that got to do with the patient? Remember, this lady doesn't have a route out the door, so we're now very nervous because we know there's been a fire in this kitchen and this patient was stuck in the house, so she couldn't have got out if that had gone wrong. Remember, the social worker wasn't interested about this. So the good news was that actually the house was really suitable for adaptations. So there was a back wall in the front room, which was her bedroom, which we could have double doors put into it and a clear pathway through around the garden to get her out. Family agreed that they would fund it and the house adaptations would happen. So that took 6 months. She stayed with us for 6 months on an acute ward. Okay, now I'd like to say we did our best for her during that time. That's probably not true. We had the equipment set up so she could be doing the return transfer, but ultimately she was their MO. It was a busy ward and I don't think really she got the time from the staff that was needed. Equally, she was getting more and more withdrawn. She did not want to be stuck in this hospital. There was nothing wrong with her at all. She was very clear that she wanted to go home. So she was getting more challenging. And the result of that was that actually functionally she was declining while she was with us because those transfers weren't as frequent as they would have been if she was at home and just living her normal life. So 6 months passed, house adaptations are done, transport go and do an assessment, sign it off, they're happy they get her in, it's all a happy day, off she goes. Failed discharge. Within 4 weeks she was back with us. She'd fallen again and the carers pulled out. They said she's too difficult, we can't manage it. So she came back to us. Family and patient decided it was time for care placement, nursing home placement, so we started looking for a facility to take her. And yet again, we were faced with there is nowhere for her to go because no one could accommodate her. So she stayed with us for another couple of months whilst the nursing home that she ended up going to also did adaptations so that they could access her in and out of the room that she was going to live in. She did then go to the nursing home. She's very happy there. It's a happy ending to the story. She really likes it, and actually they are now hoisting her, but she does get in and out of bed every day. So it's all right at the end. But what went wrong? Our fault. We didn't pick up on the extrication issues on the way in. And I'm always saying to staff, multiple ambulance crews on the way in, fire and rescue, it's got to be alarm bells. They're not going back the same way they came in. She owned her own house. It's mad to say it, but that was a problem. If she'd been in social housing, I believe we would have got her placed. But because it was her own house, she ended up getting stuck. We then didn't do the best job probably we could have done in terms of keeping her mobile. So, as I say, the one that made me think this can't be the best that we can do. My next patient. The complete opposite. I say this is the good one that turned to fabulous. So this lady is the patient that really sticks in my mind, and I'm still in contact with her now, that made me think we have to think really big with our outcomes. It's not enough to think, oh, I want to transfer from this bed to this chair. We've got to think really big out in the world as to what might happen. So this lady I didn't meet from my NHS role. I met her with my support for the bariatric rehab facility role. So she was in a different trust. I went out to see her. This is the middle of the COVID pandemic. So she, previous to her admission, had been independently mobile at home. Prior to COVID, she was completely independently mobile, had a job, went out to work, came back, was living with her partner. COVID happened, she became home working, and on reflection, she does say that actually that function was declining a little bit just because she wasn't moving around as much as she had been. She had an antibiotic reaction. She had a cellulitis and then the antibiotic reaction, which ended her up with a short ICU stay. So she came in and she ended up in critical care. She was fairly sick. And during that time, she didn't get out of bed. She was fairly sick. She says on reflection, she probably should have got out of bed, but she came in, she was sick. No one said she should get out of bed, so she stayed in bed. After the ICU stay, she got moved out onto a respiratory ward. We're in COVID, remember? So she got placed in a 4-bedded bay on her own and was completely socially isolated. And she stayed there for 6 months. Now, the therapy team did a really good job in proving that she had function. So when I first met her, she was a sister 4 to roll in bed. They had a gantry hoist in and they were hoisting her out from bed to chair. She had good sitting balance, but they hadn't done any weight bearing with her. Remember, she's quite deconditioned now because she's been sick and she's had a long period of immobility. As I say, I think the therapy team, if we think back to COVID pandemic and what that actually looked like on the floor, they did a good job improving function, but they'd hit that same barrier that I've spoken about in that they couldn't find anywhere to take her. So she's got function, she's young, she definitely should go to rehab, no rehab facility will take her. So I end up going in from the specialist bariatric facility. Now, that's far away from where she was geographically. It wasn't near to her. She's different boroughs. So we decided we would accept her. She was a really good candidate, actually. She was very motivated. She previously had worked in healthcare herself. She was an amazing advocate for herself, even in the really challenging times. And she was very clear. She wanted to get up, walk, be mobile, live her life again. So another delay occurred because funding had to be worked out, because it was going from different geographical areas. There's a little bit of a bum fight about who's going to pay for it, and the downside to the specialist bariatric facilities is really expensive. So we had to pull funding from lots of different places, but they managed to sort it out, and she comes up to join us. She does really, really well initially. So, as I say, rehab is the same as for anyone. Work on range, work on strength, turn it into function. And she did really well. It's slow stream. It was slow stream. But if we think about how long she's been deconditioned for, that would be the same for anybody, really. I don't think that's specific to the larger size person. But roll on 12 months, and she was there for 12 months, and she is independently mobile, walking with just a frame. And then she moved on to sticks. So that was fabulous. And it says that it does work. You can do that rehab. What had happened in that period, though, is, remember, she was previously living with her partner and she'd split with her partner, which rendered her homeless because she lived in his property. So now she's doing amazingly well. She's gaining back her function. She's getting to the point where she's not really needing much care. She's having her therapy input, but she's got nowhere to go. So that brings the next challenge. Now, at this point, the funding authorities were getting a bit twitchy because, as I mentioned, it's quite expensive. It's being funded from all different areas, and her what was home area was starting to say, well, she doesn't have a house here now, so nothing to do with us, so we'll probably fall the funding on that. This still baffles me to say it. So remember, I said this lady's young and she's a really good advocate for herself, and she really wanted to own the decisions that were happening around her, where she would live, who would support her. The services did not want to engage with her. She repeatedly called MDT meetings herself. She wanted everyone to come in, and they were always cancelled, and no one would turn up. One day she got news that she was being moved. She was being moved to a care home back in the area that she'd come from. No clear plan about her therapy or her onward destination. She said, I don't want to go. It battered forwards and backwards a bit. It got to the point where actually they sent transport to pick her up and take her against her will. Now, she was really brave. She said, I'm not going. You can't make me. I'm not going. And the rehab facility supported her in this and said, we won't evict you, don't worry. But we had transport there at the door saying, you've got to come with us. You're going to live here. With her saying, no, I'm not. No one's consulted me about this and I'm not going to go. So she didn't go and she stayed where she was. This goes on for months, batting forwards and backwards. And the social workers will not talk to her. It feels like they were going out of their way not to include her in the decisions being made about her care. And the more she kicked up about that, the more they tried to avoid her. It has a good end. She does finally transfer over from a funding point of view to where she is. So it now becomes local authorities' issue to house her in the area where she's been with the rehab facility. During this time, because she's been kicking around for quite a while now, she's found a taxi service that's able to take her out and about. So when her friends come to visit, she's going off out into town to have coffee, to meet them, to see people. Her dad's coming to visit, he's staying over. She's really living a fairly independent life from this rehab facility. So they find her a placement, so she goes to a supported living facility, which not ideal for her. She's 49, she's still young, but it's better than where she was. So she moves into this supported living facility, which everyone thinks is absolutely fabulous. Wheelchair services provider with a motorised wheelchair. So from her supported living facility, she's now able to get in her wheelchair and go into the community and engage with the community. She gets herself a home working job, so she's working from home. All great. I actually spoke to her just last week. I was still in touch with her, and they're now moving her. They found her a bungalow, so she's now moving from the supported living facility into the bungalow. Well, she'll continue with her job. She'll still be able to get out and about and go and integrate with the community around her, and she can really continue to live her life. As I say, big outcomes. We need to remember that it does work, and you've got to be thinking about that on the way out. But things that we could have had done better here from this point of view, I mean, it's the age-old problem. She had to go out of area to get her rehab, and that was always going to bring about the problems with funding and onward destination. But she had to do that because there was nothing in her area that was able to support her, despite the fact she had really good rehab potential, which we managed to realise. Yeah? The fact that no one would talk to her. So this lady was really able to advocate for herself. And I really believe if she hadn't been able to advocate for herself as well as she did, she wouldn't be where she is now. And she says to me still to this day, she says, when I was in hospital and it was so tough and there was nowhere for me to go, she said, I really did wonder whether actually I should just give up and accept I'd be bedbound for the rest of my life. She didn't. She's such a strong character, and I think that's why she's got so far. But you can imagine for those that don't have the strength of character, that don't have the ability to advocate for themselves, how many other patients have been through that situation and actually are living out their lives bedbound when we know it can be so much better. So, what do we need to do to fix it? Equipment. The equipment has to be better. I look at every Medstrom person in the room as I say it. Whilst the way to rehab larger people is to do complicated things using lots of different bits of equipment in really cool ways, which if you know how to do it works really well, it will never be mainstream. I talk a lot about palliative care. As soon as that patient comes in, we've got duty of care to them, whatever size they are. And if someone of a standard size has access to equipment, toileting, getting out of bed, a chair to sit in, that should be exactly the same for our larger population. But the equipment for early mobilisation has to be there to make it every day. Otherwise, there's always going to be the delay, but always going to get the deconditioning. Improving the skills and the knowledge, I think that goes hand in hand with the equipment. If we had the equipment that was easier, you wouldn't need so much skill set to be able to do it. But at the moment, as I say, whilst we rely on the fact it's all a bit complicated and you do need someone with that increased skill set, patients are always waiting for that person to come along to help them out. It's not just normal that they come in and they get out of bed, and it absolutely should be. Thinking bigger picture, and Kaz was kind of talking about this already. Access to facilities. So if other people can go to step-down beds, to rehab facilities, so should the larger population. There's absolutely no difference. But we should have facilities within each locality that are able to accommodate people so that if there's rehab potential, they can immediately go onto that rehab and have the same journey that anyone else would do. I think from the joined up working point of view, I see people the whole journey, the whole way through. And I think often these patients fall in the too difficult box. So like with my first patient, once she'd come to acute care, the social worker said, oh, your problem now, I'm out. And actually, we've got to be thinking about that full cycle, the whole way work through. People will get sick, they will need to come in, and then they will need to go back out again, and we've got to have that joined up thinking. And we really have to have those recognised pathways and the accountability. So it is not okay to say, well, that person's plus size, so we don't have a chair for them, so they're just going to have to stay in bed. But who holds anyone to account about that? We don't. If you come in with an orthopaedic injury, or if you come in with a cancer diagnosis, or any of those other specialities, there are clear pathways with clear timeframes that say this is what should happen and in this way. Plus-size people cover all specialities, but there is nothing like that. There's nothing that you can hold anyone to account about to say it's not okay that you're deciding that this person is going to be bedbound for the rest of their life because everyone goes, oh, we don't have the right equipment and it's a bit difficult, so we can't do it. That's not okay. Whilst it remains that way and there isn't the accountability, something's got to change to improve things. So I think that's me.